Good morning. Hello.
Hello.
Hope you're all doing okay this morning. So I had a couple of questions from a few people about test for this class. I just pushed it to next week. So we'll go over content this week, and we essentially have like 4 more chapters to go over, and that's it. So it's supposed to be 3 today and then 3 next time. So my tentative plan then is for next week to be our test 4. Then we would have to go over a little bit of content after the test, which is just 1 chapter. And then we could essentially take our final the following week and then just be done with the class. So is everyone okay with that?
Can you repeat that one more time, please?
Yeah, so we would do test 4 next week, which is I think the 10th. After we take test 4, we would have to meet to do 1 more chapter of content. And then the following week, we could essentially go ahead and just get our final done, really.
So like we take it next week and the following week we take the final, right?
All right, so today's the 3rd. So I'm just looking at a calendar while I'm talking, so I make more sense. So today we have like 3 chapters to go over. So we're going to get that done. Then next week on the 10th, we could take our test, right? So that would be test 4. Actually, we could do it this way too. So next week, if we want to do that test 4 and just leave it at that and not do any content that day, then on the 17th, we could meet and just do the 1 chapter. And then we could do some review for the final and then just do the final on the 24th if you want.
Yeah, that sounds a little better.
That sounds
Yeah.
better?
Yeah.
Okay, so the 10th will be test 4, the 24th will be our final then.
Okay. Is our like semester extended then from all this?
I heard that it is. I heard that I think officially by the 30th, everything is supposed to be done.
Okay.
Yeah, so that's kind of what my plan is for this class. And then when we have our other class, I'll talk to you about that on that day.
Okay.
Okay.
So Cynthia, so you need to contact IT about your computer so
I
that
did.
when
I was off yesterday and they said it's working.
so you got it fixed.
They said that they could see my screen, so I guess so.
Okay, well, hopefully it's all right. So I just want to make sure before we take another test that we don't have another issue. That's all.
Do you want, they said you can create a link for me and the 2 of us do it and try it. We could do that if you want us to do that.
Okay. Well, when we're done with talking here this morning, if you remind me, I'll see if I can try and do that with you.
Okay.
Okay, also after the lectures, can you go over the chapters for the test 4 again?
Tell you which
Because
chapters it is.
Yeah, because I'm sure it's going to include this chapter we're going to talk about.
Okay. Yeah, I can do that. So Consuela, are you on here? She must not be on here. She's the other one I need to get her computer fixed. Is Krishna on here at all? I don't see her. Okay, so let's go ahead and just get started. We're going to do chapter 6, chapter 9, and chapter 10 today. So that's the stuff we're going over today. So I'm going to go ahead and show you my screen. Can you guys see that okay?
Yes.
Okay, thank you. Okay, so in this chapter, it just talks about some different kinds of healthcare services that older adults can get. And it just talks about our role, you know, what our role would be in these different healthcare services for these older adults. So on this first slide, it talks about Medicare and Medicaid. So we need to kind of know the difference between the two. So Medicare is for people 65 years or older and those who have permanent disabilities. There are 4 parts to Medicare. They have Part A, B, C, and D. And I'm going to tell you a little bit about each one of those. So Part A, this is your insurance for hospital stays, home health care, and hospice. Part B is insurance for outpatient and provider services. So like, you know, say you had to go get physical therapy or something like that as an outpatient, that would be what would cover it. Part C is a Medicare Advantage or supplement plan. So maybe if your other coverage doesn't cover the whole amount or something, this would kind of kick in to help you out more. And then Part D is medication coverage for those eligible and requires a monthly premium. So Medicare came about back in the 1960s. It was somewhere around 1965. And this stimulated a major change in the delivery of how healthcare services were for older adults. Okay, this also mentions Medicaid. So Medicaid is something that is for clients who have low incomes. It's federally and state funded. And then each individual state determines eligibility requirements. So like our requirements for Ohio might be different than they are in another state. So the whole idea behind Medicaid is that it can provide health coverage for people with low incomes, families and children, pregnant women, older adults, and people with disabilities. Okay, and then it says, hey, is this following statement true or false? After the establishment of Medicare and Medicaid in 1965, few new models of care emerged to address diverse healthcare needs of older adults. This is false, because after this was established, all kinds of new models of care emerged. Okay, so this slide starts to get into what they call community-based services. So again, this whole chapter is just about all these different types of services for healthcare that older adults can get. So when we talk about community-based services, this would be things like home delivered meal programs, for an example. So these would be public and private agencies that provide all these different types of support services for older adults. It could even be like one of those companies that you can call to get a ride to go to, you know, the doctor's appointment or something like that. So eligibility criteria for these services is going to vary service to service, of course. Resources may improve health, functioning, and quality of life. And then some of these community-based services will address barriers to service. So like sometimes people, let me give you an example of something they say in the book. So they say African Americans have higher levels of unmet needs for community-based services. And they say, why do you think that is? And they say it's because of lack of awareness, reluctance to use public services, and lack of affordable and available services in their communities. So us as nurses, we need to like try and figure out how we can address these barriers so we can get them, you know, the help that they need. So I guess just like word of mouth is kind of a good thing. A lot of times people just haven't heard of something. So if you tell them about it, then maybe they'll be more apt to use it and they'll tell other people. Another thing this says is community-based resources and services. Some examples would be like the Area Agency on Aging, energy assistance programs, and also senior centers. Okay, so there are, again, we're still talking about community-based services. So there are quite a few different types of those services out there. So there are health promotion programs that you could utilize. So these would be places where, you know, if someone went there, they might be able to get like, you know, preventative health services like immunizations maybe, or maybe they, you know, have educational programs about safe seatbelt use, or, you know, anything like that. So senior centers are part of the health promotion programs. This would be where older adults get periodic health screenings and health education activities. So, you know, they could have special speakers that come in and talk about different things specific to older adults. Like, you know, maybe they'll talk about fall risks and, you know, how they can prevent falls, or I don't know, maybe they talk about skin cancer and things they could do to prevent that. This also mentions faith community nursing. So have you guys heard of something called parish nursing?
Yes.
Do you know what it is?
Not really.
Okay, so when I was in nursing school years ago, this was like just brand new coming out. And I thought it sounded really cool, but I don't know if it really took off as much as they thought it was going to. In a lot of bigger churches, they have what they call a parish nurse. And this nurse is like, she's in a role where she kind of does a bunch of different things for that community. So like say her responsibility is for the health of that community basically. So she could, you know, set up a blood pressure screening where she, you know, maybe has some of her friends come into the church and they all like set up this time where they check everyone's blood pressure. She may be responsible for, like, you know, say you hear about someone in your community, in your church, that just recently got diagnosed with cancer. Well, the whole cancer thing is very scary, and sometimes you don't really understand how to go through the whole process the right way about, you know, oh, now I need to go to my oncologist, now I need to go do this, now I need to go do that. And maybe you don't quite understand everything really well. So this parish nurse, if she is there for you and helps you through the process, she can help explain how things are going to go, make sure that you get the supplies that you need and the things that you need during that whole process. So they do quite a few things, and it's kind of nice because they're really more focused on that community itself. Okay, the next thing is respite services. So this is where caregivers can be relieved from periodically, you know, from taking care of their older adult or whoever they're taking care of for a little bit of time. So like, say I take care of my dad, and my dad is, you know, 80 some years old or something. So I take care of him on a daily basis, and it gets pretty stressful after a while. And maybe I just want to take a couple days and go for a little vacation with my family without having to deal with him. So there's certain places who will take them in just for a couple of days to take care of them while you're gone. And then you can come back and get them and go on with your daily stuff. So that's kind of what respite services are. There are some that just do it for the day as well. So like, say you had, a doctor's appointment or something and you couldn't take your dad with you, then maybe you would drop him off at this place and they would take care of him while you were gone. Adult day centers. These provide structured social and recreational activities for functionally impaired older people. I don't know, you guys haven't had this, but in the ADN program, when they do their older adult rotation, they actually go to an adult day service place. And they talk about it and they say it's really fun. But basically this place that they go to for clinical, it's an adult daycare center. So there's quite a few people who go there and they just do these different activities with them and like talk to them. And, if those older adults that are there for a certain amount of time during the day need medicine, then there's a nurse there who actually administers their medicine. And sometimes the students get to help with that. So it's kind of a neat, interesting place. Just kind of a different way of taking care of people. All right, and then the last thing here is it talks about geriatric care managers. So this is a primary care coordinator who's responsible for implementing immediate and long-term care plans as the needs of the older adults change. So I guess it's kind of like a case manager in a way. So, but it's just, for an older adult. So if you have a case manager, in the community, like here's kind of an example, but this isn't for an older adult. So you know how I've talked about my sister-in-law before who has muscular dystrophy. So she is young still, she's in her 40s, but she actually has like a case manager. So, and this was more so when she still lived at home. So this case manager would check in with her every so often to make sure that, she was having the care that she needed. And if there was any kind of supplies that she needed or anything like that, she kind of facilitated all of that for her. So that's kind of what this type of person would be like. Okay, so then this gets into home-based services. So this is where, you start talking about home health care. So skilled home care. So this addresses needs for those recovering from illness or injury with potential to return to previous level of functioning. So, so in addition to the nursing assessment and interventions, skilled nursing services can include case management, medication management, infusion therapy, intravenous antibiotics, and also psychiatric nursing care, which I thought that was kind of interesting. So for this type of home care, this would be something that's ordered by your primary care physician. They could tell, if you needed skilled or rehab services just by like how you do while you're in the hospital. And then some of it could be either just intermittent, or maybe it's going to be more full-time care, or maybe it's just short-term care. It just depends on the situation. So if you did do short-term home care, your major focus would be on teaching the older adults and caregivers about, being able to take care of themselves, because you're not going to be with them for very long. So you want to make sure that they understand how to do everything they're supposed to be doing for themselves. So for this type of service, Medicare will cover this. It will cover, physical therapy, occupational therapy, nutritional counseling, speech therapy, all of these things that it has listed here. Then they mention non-medical home care. So this is something that addresses the needs of people with chronic or declining conditions who do not qualify for skilled care. So remember, the difference between skilled and not skilled is skilled would be someone who is recovering from an illness and they expect you to be able to return to your normal functioning. And then if you're not skilled, then maybe they don't think that you're going to get better enough to be like that. So with non-medical home care, this would address the needs of people with chronic conditions. So there's all kinds of different services out there that can help with that. So, maybe you just need someone to come in and clean your house a little bit for you because you're not able to do it. So light housekeeping would be one thing. Maybe you just need an aide to come into your house to help you with personal care every so often. So maybe every other day you get someone coming in to help you with your bath. Could be someone who does your grocery shopping and other errands for you, or even just someone who does meal preparation. So any of those types of things would be services that would fall under this. So a licensed nurse may assess the client and supervise the services, and a registered nurse usually assists with medication management if needed. Okay, so then this talks about sources of home care services. So believe it or not, you would think all home care is the same, but it's really not. There's different types that you can have. So there's formal sources where there's like an agency that you go through. So, like a visiting nurse would be a nurse agency that maybe you would get nursing services through them. Or I know there's someone called Cambridge Home Health Care. That would be another example of a formal agency. And then there's places like informal services where you would have an independent caregiver or someone that takes care of you by word of mouth. Like again, my sister-in-law, when she used to live at home, she would have independent caregivers come in and help her out every day of the week. And she would have a hard time getting like a good, decent, independent caregiver. So, and then the last thing they mentioned is geriatric care management services. So this would be someone that's helpful in arranging services and overseeing care. So again, more like a case management type of a thing. So with these different types of services, so with the formal ones, so these agencies usually provide initial assessments. They arrange for services. So if you need other types of services, like we were talking about with maybe you need aides to come in every so often, they would help arrange all of that. They provide ongoing supervision and collect payment for services. So that would be them. And then with the informal, so the care recipient or surrogate decision maker is responsible for supervising and doing organizational tasks like hiring and firing. So this means that if you were the patient and you were trying to find this independent caregiver to come in and take care of you every so often, you would be responsible for hiring and firing them. So like my sister-in-law was the one that had to make that decision on certain people. Okay, so this is the different types of roles that nurses have in these different types of settings. So, and this is, in home care basically. So home care nurses do a ton. I don't know if any of you guys work in home care right now, but wow, they have such a huge job. So you have someone who can be in the role of primary coordinator of their care. So this person would coordinate everything that this person needs. And they work in a multidisciplinary team. So they work with others to figure out what works best for that person. There's other people who would just do assessments, hands-on care, health education, referrals, all of these things. So those would be some of the stuff that a home care nurse would do. And then the challenges would be keeping up with the technological advances. So for example, telehealth monitoring. So it's a way to collect and transmit health information to a healthcare provider. So for example, people with congestive heart failure or hypertension or COPD, they may have telehealth. So it helps to keep them out of the hospital for frequent readmissions. So like if I was a person who had telehealth and I had congestive heart failure, my machine that I have at home might collect a little bit of information on me daily. So like it might like collect my weights and send them off to my physician. It might, trying to think what else they do. They probably do vitals once a day or something. So they would do that, send it off to the physician. And it might ask you certain questions that you have to answer, and then you just click yes or no, and then it would send that off to the physician. So it's a way that they can kind of keep track of you if you have more of a serious type of a problem, and they can just kind of make slight adjustments to your care, and they would, maybe call you and say, okay, I see that your blood pressure was this and your weight was this. Today, I want you to take this much Lasix, and I want you to not take this pill or whatever. So they would kind of just make adjustments that way without you having to come into the physician's office to do anything different. Does that make sense?
Yeah.
All right, then we talk about nursing home settings. So the nursing home or nursing facility would be a residential institution that meets the needs of, older adults with ADLs and other care. So usually it's licensed by state or federal agencies. It's certified as a Medicare or Medicaid facility, and it's required to have continuous on-site supervision by a registered nurse or an LPN. They must provide dental, podiatry, medical specialty consultation services, and also rehab services. And you can be in a nursing home in a short-term way or a long-term way. It just kind of depends on what you have going on. So the quality of care in nursing homes has kind of changed over the years. And I know everyone still kind of has the same view of them for the most part, but there is a different type of culture change that's going on right now. So it used to be that, you go into a nursing home and the nursing home themselves would like kind of dictate how your care was going to be. They didn't ask you anything. You weren't involved in the care whatsoever. So now the change is more like a residential or like a resident-centered care. So it emphasized personal choices, quality of life, instead of overemphasizing safety, uniformity, and medical care. So in other words, this means that now nursing homes will kind of give you a little bit more say in your care. So they may involve you in decisions about what you're going to do. And maybe you get to decide if you go down to the dining room and eat or not, or if you stay in your room and eat. Or maybe you get to decide when is your bath day and when is not. Like you actually get some decision-making ability. So it's kind of a little bit nicer that way. So the roles of nurses in these settings, leadership would be something. So maybe you're a nursing supervisor or a director of nursing or a wellness nurse. Education of best care for residences, or gosh, I can't talk, residents. So this would be, teaching nursing assistants about best care for residents. So like, you work with people all the time with these residents, and you want to make sure that they are taking care of patients like you want them to. So if they don't understand the importance of turning someone or getting them up, then you talk to them about it so they understand. Consultants of planning and implementation of care. So in the 1990s and 2000s, advanced practice nurses were recommended for improving quality of care. They provide staff education, they assist with program development, and they act as consultants in planning and implementing care. So you will see a lot of nurse practitioners that actually see residents on a pretty regular basis in certain nursing homes. And so that's more of a newer thing that they kind of are based there now. So they kind of help increase the quality of care that they're given. And then always, in a nursing home setting, we have to be an advocate for the patient and for their families. Okay, so with hospital settings, older adults are kind of, they keep the hospitals in business, really. So they account for 43% of inpatient hospital visits in the United States. They always have unique needs. So older adults, especially because they have a lot of different comorbidities and stuff. So acute care units for elders. So certain hospitals will actually have a unit that they will call, like at SUMA, they call theirs the ACE unit. So I forget exactly what that stands for now, but it's ACE unit. That unit is specifically for older adults. So most of the people that are on that unit are older adults, and they actually meet. There's like an interdisciplinary team that meets every day on each one of those patients. So they have this big meeting and they talk about different aspects of their care and what's going on with them. So all of these people are like experts in older adults. So it's kind of nice. They really give them really good care. So these types of units, they are really helpful for older adults because they decrease the risk of functional decline. They will decrease their length of stay in the hospital, and they decrease their risk of complications. Okay, so then this kind of gets into a little bit about resources for improving care for older adults. And of course, you guys know we constantly are looking on that one nurse website that talks about older adults, you know, that Hartford Foundation that we always talk about. So that's a really good resource. And then there's something called Nurses Improving Care to the Hospitalized Elderly. That would be another good place you could go to. And then the Geriatric Resource Nurse. This is someone who is a consultant that is like a role model for other nurses. So this nurse is skilled in identifying and addressing geriatric syndromes, implementing interventions that discourage use of restrictive devices and promote patient mobility. So that would be something else you could do. And then this talks about the transitional care model here at the bottom. So I'm going to get into a little bit about that. So there's 3 components of the transitional care model. So the first thing, nurse discharge advocate whose primary responsibility is to coordinate discharge plans and communicate with family and healthcare providers. So again, that first one is someone who is a discharge advocate for the patient. So they coordinate discharge plans and tell the family members what's going on with that. Number 2, an after hospital discharge care plan document that is patient-centered, low literacy level, and high pictorial that includes pertinent information. So this means after this person gets discharged, or actually even before, so you have like discharge papers that you give this person. So this is saying that the discharge papers are going to be low literacy level, so they're easy to understand. They're going to have pictures on them even, so that if this person has a hard time understanding, they're going to be able to look at the pictures to be able to get it. And then it's just going to give you like the most important information that you need. So, hey, this is the type of diet you're on. This is the follow-ups that you need, you know, just the important information. And then number 3, so telephone follow-up by a clinic pharmacist 3 days post-discharge for teaching and follow-up. So this means after this person gets discharged, they still are going to follow up with them 3 days later, and they're going to try and do some teaching with them about their medications and making sure that they're not having any difficulties with anything. So when people have transitions of care, this means that they go from one area to another. So like maybe I go from home to the hospital, and then I go from the hospital to the nursing home. So these are all different transitions of care, and certain things will, anyone who has like a transition of care like that, they're going to be at risk for safety issues and some other things. So I'm going to read off some things that are factors that affect transitions in care and compromise patient safety. So one of those things would be communication gaps. So I don't know if you guys have come across this yet or not, but sometimes when you get report on someone, people don't give good report. So they leave things out, and like there's communication gaps about stuff that is kind of important to know. Also, incomplete transfer information. Inadequate patient education, particularly for older adults and their caregivers. Also, ineffective medication reconciliation procedures. So again, you know, that medication reconciliation is super important. So if it doesn't get filled out right, that's a huge safety issue. Poor coordination of services is another thing. Lack of access to essential care services. And then certain patient characteristics will put them more at risk for safety issues, like especially if they speak a different language, if they have a low health literacy, or if they have a cultural difference, they're going to be more at risk. So anyway, knowing some of these things, what do you think is something really important for you to do as a nurse to make sure that this patient has a safe transition of care? You guys still with me?
Yes.
No one wants to answer my question?
I'm thinking.
So you see, we see a lot of people who have a different culture than ours that are transferred from one place to another. So you would want to definitely make sure that you take it upon yourself to make sure that they get the education that they need about the stuff that they need, right? So knowing that when they move from place to place that things get kind of messed up, you would want to make sure that when they are with you, wherever your place is, that you talk to them and tell them all the things that they need to know when they're with you, so that it's not missed when they go somewhere else. And
Right.
if you have the ability to, like, you know, do things in their language, you know, like your discharge papers, maybe you can print them off in their language. That would be great, because then you know for sure that they're going to understand what you're talking about. Any other thoughts? Okay. All right, so it says, is the following statement true or false? Subacute care for elder units addresses the complex needs of hospitalized older adults through multidisciplinary assessments and interventions.
True. False.
This is false. So acute care for elders, that's what the ACE stands for, I forgot that. Those units address the complex needs of hospitalized older adults through multidisciplinary assessments. So the question was, you know, is it subacute care for elders that does this? So it's more acute care.
Okay.
Okay, so this gets into the CUSIN and safety initiatives. So every time, I don't know if you guys have noticed this yet or not, but in every book pretty much that you guys would have, whether it's online or like physical book, you'll see these CUSIN initiatives everywhere. So everything that you get taught through nursing school should kind of, you know, address these things. So like CUSIN initiatives these are what some of them are. So making care safer. We always want, you know, safety is like #1 priority all throughout nursing school. Ensuring person-centered and family-centered care. You always want to make sure that the patient and the family have a say in their care, that they are updated all the time, that they're able to give their opinion about things, you know, all of that kind of stuff. You want to promote effective communication and coordination of care. You want to promote the most effective strategies for preventing and treating the leading causes of mortality, starting with cardiovascular disease. And you want to promote wide use of best practices that support healthy living. And then make quality care more affordable. Those are some of the big CUSIN initiatives. Okay, so addressing the needs of caregivers. So we know that as a caregiver, when you take care of an older adult, it is very stressful. You can have financial burdens, physical burdens, psychosocial problems that affect family members that are caring for the older adult who are impaired and suffering from the illness. So some functional consequences that are associated with caregiver burden would be depression, disturbed sleep, social isolation, family discord, career interruptions, financial difficulties, decreased time for self, poor physical health, psychological, emotional, and mental strain. Okay, so this talks about, paying for some of these services now. So sometimes people are self-pay. So that can be hard if you are a self-pay and you don't have coverage from other things because it's expensive to do anything. So Medicare does not cover costs of nursing home care or assisted living facilities. And I don't know if you guys are aware of how much that costs, but it is like ridiculous. So and I'm not sure what date this is from, but for assisted living facilities, approximately it's going to cost about $3,450 per month if you have a private room in an assisted living facility. If you are in a nursing home, it's going to cost $6,996 per month. If you're in a private room in a nursing home facility. I believe that's just quotes from our book, so it may be a few years old, so it may even be higher than that now. Anyway, so private insurance would be kind of a nice thing to have because insurance would then kick in to help you pay for some of that. And then there's also some people who have government-supported programs like Medicare or Medicaid, and then some people even have veterans assistance stuff. So I don't know if you've ever taken care of someone who was a veteran before, but a lot of them will go to the VA hospital and they'll get their care taken care of like nothing. It's just awesome. So they really take care of the veterans well, which they should, Okay, and then there's sometimes a lot of out-of-pocket expenses that people have to do. Certain things your insurance won't cover, so you have to kick in and pay for it yourself. Other things that this talks about, Medicare has certain federal health insurance programs for people who are eligible of Social Security benefits. Medicare supported comprehensive models, they have something called an ONLOC senior service program. This began in 1971, and it was the first senior day health center. And then that PACE program, it's a program of all-inclusive care for the elderly. So this program is kind of cool. It has provision of comprehensive and community-based long-term care services to nursing home eligible clients. It emphasizes preventative services, case management through multidisciplinary teams, and then also full funding on a capitation basis. So the core components of this program are nutrition, transportation, home care, acute care, respite care, primary care, social services, restorative care, and prescription drugs and long-term care. All right, and then so sometimes people fall into that like gap where their insurance doesn't cover something, or maybe Medicare or Medicaid won't kick in for a certain period of time or something. So there is a supplemental policy out there that attempts to fill the gap between the services covered by the original Medicare and paid out of pocket expenses. So that does exist. It just mentions a bunch of different types of things, that you can use to help pay for some of these services. So there's long-term care insurance. This is policies that cover long-term care expenses that are not covered by health insurance programs. Okay, what setting provides a combination of skilled nursing for short-term post-hospital residents and intermediate care for services for long-term residents? This would be nursing homes. Is this statement true or false? Skilled home care services provide long-term skilled nursing or rehab services for homebound people who meet specific criteria. This would be false.
False.
So skilled home care services provide short-term skilled nursing or rehab services for homebound people who meet certain criteria. What model of care is focused on the coordination and continuity of care as individuals transfer between locations of care within the same facility? This would be that transitional care.
Transitional care.
Mhm. All right, so that's that chapter. So the stuff that I would focus on in that chapter is definitely the difference between Medicare and Medicaid, because I'm pretty sure you have a couple of things on that. And then maybe just like that transitions of care stuff, that would probably be a really good thing to look at as well. In your ATI fundamentals book, in chapter 1 of that, there is a chapter called Healthcare Delivery Systems, and there's a little thing in there about Medicare and Medicaid that you could read that might help you. They also talk about different levels of healthcare and stuff in there too. It's kind of a good chapter. Okay. All right, so this chapter is going to be kind of familiar a little bit because in our other class, we did talk about legal and ethical stuff already. So some of this will be very familiar to you. So that's a good thing. So this chapter talks about ethical dilemmas and legal and ethical considerations regarding, older adults. Okay, so the first part of this talks about autonomy and rights. So autonomy just means personal freedom to direct one's own life as long as it doesn't infringe on the rights of others. So meaning that I can make my own decisions about myself as long as my decisions don't affect the well-being of someone else. So with older adults, for them to be autonomous, they have to have a capable, rational thought, and they need to be able to recognize the need for problem solving. So a lot of times older adults will have this loss of autonomy that they have, where they have a loss of independence. And this is a real fear with many older adults. And you can understand why. It would be hard to not be able to do your own thing anymore. So nurses need to be familiar with legal and ethical guidelines related to competency and decision-making capacity. So if the safety of an older person is threatened because of risky behaviors arising from impaired decision-making abilities, nurses must refer older people to the appropriate community agencies like Adult Protective Services So like if you were out in the community somewhere and you saw someone doing something kind of crazy that you were worried that their safety was going to be an issue, you always call Adult Protective Services about that. So again, if someone is able to make their own decisions, they're autonomous, they are able to capably identify that there is a problem, that they search for alternatives to figure out how to solve it, and they select a solution that allows his or her continued personal freedom. So in other words, they make a decision that is appropriate for that problem, and it doesn't hurt anyone else in the process or themselves. Okay, which of the following best describes autonomy? This is going to be personal freedom to direct one's own life if it doesn't infringe on the rights of others. Okay, so then again, sometimes when we think about someone like this in the community, we may wonder if they're competent enough to make their own decisions. So when we think about competency, this refers to someone's ability to fulfill their role and handle their own affairs in a responsible manner. All adults presumed competent for participating in legally binding decisions. They have to have the right to make healthcare decisions unless declared incompetent by a court of law. If a person is deemed incompetent, the judge assigns either a partial or a full guardianship or conservatorship to a designated person. So can you guys think of someone in, you know, kind of in the news, in the pop culture that we know who has a conservatorship right now?
Not really.
Britney Spears,
Oh,
right? She has a conservatorship even today still. And it's her dad. Her dad is her conservatorship. He makes
Hmm.
her decisions about everything still.
well, she's
So
competent enough to do that, right?
what's that?
Isn't she competent?
Well, they must not think so still because she still has that going.
Well,
Yeah. She has some mental health issues, so that's why that was put into place.
Oh, makes sense. Okay.
So with this competency thing, sometimes you'll have, you know, maybe you have an older adult that you're taking care of in the hospital who has to get some kind of procedure or surgery or something, and you're wondering if they can really make a good decision about whether to have it or not. Then they will call in like a psych consult, and the psych person will come and ask them all these questions to determine how competent they are, and then they kind of go from there with deciding whether they're competent or not. So the age of competency is going to be 18 years old and older. So that's considered, you know, someone who's able to make their own decisions. Okay, so a measure of older adults' ability to make an informed decision about an aspect of healthcare. So they look at their executive control or executive functioning. So this is looking at their cognitive skills involved in successfully planning and carrying out goal-oriented behaviors, such as self-care tasks. Things that can cause impaired executive control would be a stroke, dementia, major depression, Parkinson's disease, and also traumatic brain injury could do this. So anyway, this person, you know, when we're trying to decide if they can, you know, make their own decisions appropriately, they need to be able to understand, to make and be responsible for the consequences of their healthcare decisions. So again, like if you were talking about a surgery, you would have to make sure that they were able to understand everything involved with that to make their own decision. Okay, decision-making capacity is best determined by which criterion?
See.
Yeah, so it's going to be the ability to understand pertinent issues. Okay, so this chapter gets into a little bit about advance directives. Advanced directives would encompass a few different things. So these are legal documents that allow competent older adults to document medical care that they would or would not want to receive if they weren't capable of making decisions and communicating their wishes themselves. So typically this would be like the durable power of attorney or living will that people usually would fill out. So you need to have a healthcare proxy or decision maker in some of these. So you have to designate someone to make these decisions for you. This person is responsible for communicating that person's wishes if they become unable or incompetent to communicate their decisions of care. So like if I had a durable power of attorney and I designated that as my husband, and then I, Lord forbid, got in some kind of horrible accident where I was on a ventilator and I didn't want to be, and I had that in my durable power of attorney, then my husband would have to be like, hey, here's her durable power of attorney. She didn't want to be on this, take her off the ventilator. Patient Self-Determination Act. This is a legal mandate for advanced directives. This requires that providers do the following. So they have to inform the patients of their right to refuse treatment and make healthcare decisions. They have to provide written information about their state's provisions for implementing advanced directives. They have to ask each person whether advanced directive has been completed and include the documentation of those things on their medical records. Excuse me. They have to provide education for the staff and the community on the advanced directives as well. I have really thought about this quite a bit recently. I had a relative of mine, it's my aunt's husband. They both just came back from Florida, and they were only home maybe a half hour when this happened. So her husband is like 77, something like that. Anyway, she was in the kitchen and she heard this loud bang. And so she went out to see what happened, and here he fell down the steps. And they have like these really steep steps. So he was all the way at the top and fell all the way down. So he was unconscious and definitely hit his head and had a head injury. So they took him to the hospital. He's still there today. But yeah, so I don't know if he's going to make it through this. It's pretty bad. He has a couple of fractured vertebrae. He could be paralyzed. He has one of those halos on his head, you know, to stabilize everything. He's on the ventilator because he can't breathe on his own still. All kinds of stuff. So this really made me think about advanced directives recently. I thought, you never know when something's going to happen. So it's always a good idea to have that documented somewhere. So, you know, if something happens to you, you know, you're not in a situation you don't want to be in.
Right.
Okay. So the durable power of attorney for healthcare, that's that surrogate health decision maker. They represent that person when that person is incapacitated. So, you know, the durable power of attorney doesn't kick in unless you can't make those decisions yourself. If you're incapacitated, that's when that person would make decisions for you. So that's really important to remember. So this must be initiated when the older adult is competent and takes effect only when that person is incapacitated. Nurses should encourage the older adult to discuss their wishes with primary care providers and pertinent other healthcare providers and designated surrogate before a crisis develops. So super important to do it way in advance. Then there's something called DNR orders. So this is a specific type of advanced directive that compels a healthcare provider to refrain from CPR if there's no sign of breathing or no heartbeat. So it says, do not mistake this order to withhold other medical treatment, because you could still do other things. This allows a natural death, a preferred term over DNR terminology, and there's three codes. So 1 would be full support, 2 would be intermediate support, and 3 would be comfort support. So the comfort support would be like your DNR, CCO, Um, so, you know, this how it the term says allows a natural death. They like that instead of saying DNR. That just sounds too rough, I guess you could say. Okay, so with the living will, this is has the purpose to guide decisions about care provided or withhold certain treatment under certain circumstances. So usually at the end of life or when a person is considered terminally ill is when you would do something like this. This is evolved as a component of the first right to die statute. It must be, this person has to be competent to initiate this, you know, and can change or revoke it at any time. So this applies only to situations where a person is considered terminally ill, whereas other advanced directives may apply to a broader range of circumstances like brain damage or temporary incapacity. The scope and details differ from state to state with living wills. So some states require living wills specifically to address certain procedures like withholding or withdrawing artificial sustenance. Okay, which is a limitation of a living will? So it's going to be C. It applies only to the end of life or terminal illness. Okay, so then this talks about medical orders for life-sustaining treatment. So physician orders for life-sustaining treatment directives would be medical directives effective for ensuring that patient preferences are known and honored in all healthcare settings and situations. So this addresses questions about treatment at the end of life. So like maybe if you knew that this person had like a bad type of cancer or something, then maybe you would bring this up with them at their appointment and you would talk about these different things. So this talks about, will treatment make a difference? So, hey, if I did this radiation, is it going to make a difference in my life? Do burdens of treatment outweigh its benefits? Is there hope for recovery? What will life be like afterwards? What does the patient value? What is their goal of care? So this makes me think about another thing I just heard about recently. So one of my coworkers, they have a sister-in-law who has cancer, and she's probably going to die here shortly. She's really not doing very well. She's just in her 50s, and she has pancreatic cancer. So this cancer has evolved over a short period of time, and now it's in her brain, and it's just really bad. So anyway, when she found this out a few weeks ago that it spread to her brain, the physicians and everyone were like, oh, let's do some radiation. It's going to, you have to get this thing implanted in your head, and it's going to help, you know, prolong your life for a little bit longer. So she was like, why would I want to prolong my life like this? My life is awful right now. I feel horrible. And what's the purpose of that? So she said no to that. She didn't want to get radiation. And then again, do the burdens of treatment outweigh its benefits? You know, thinking about that, why would she choose that? You know, it just depends on what the person wants and what they value. So like she is just valuing spending time with her family and not trying to not be in pain, and, you know, trying to tell everyone everything she wants to tell them before she dies. So that's kind of like what this makes me think of. So definitely, you know, sure, give them options, but make sure that they have the last say in what they do. So has anyone out there heard of 5 wishes?
Not really.
Yeah, this is the first time I ever heard about it from our book. So this is kind of interesting. Maybe you guys, when you're done here, you can go look at this online. So this is a thing where you can actually go online, and there's like a 5 wishes website. And this is a document that addresses your wishes when you're, you know, close to death or whatever you want. It's very similar to an advanced directive. And certain states will accept this as your advance directive. Unfortunately, Ohio is not one of them, so we can't do it. But so anyway, this Five Wishes website is very nice because it's very straightforward and like on, you know, the basic person's level. It doesn't talk over your head like a lot of those forms do. If you've ever looked at one of the advance directive forms, it's kind of hard to understand like the wording and stuff. So a lot of people get turned off by filling one of those out because they don't understand what they're filling out. This is more like you're able to understand what you're agreeing to on this website. So I kind of wish that this would, you know, be more adapted to everywhere and not just certain states. So anyway, it's just a website. You fill out all of the stuff at what you want, and then I think you could print it out, and then you could give it to your physician or whoever, and it's considered like a legal document. So this is Aging with Dignity promotes the use of 5 wishes. So it addresses the following: who you want to make your care decisions when you can't make them, what kind of medical treatment you want or don't want, the level of comfort you want, how you want people to treat you, and what you want your loved ones to know. So this was introduced around 1997, I think. And it meets legal requirements for advance directives in 42 states. And in other states, it can be attached to the state-issued forms. So like, I guess if you did fill it out here, even though it's not accepted in Ohio, they would attach it to your living will and durable power of attorney, so they would have it. There are also e-planning websites. These are technological advances that help persons engage in advanced care planning. So that's kind of nice. A lot of people think it's kind of hard to do some of that stuff, so this would make it a little easier for you and guide you through the whole process. So the Making Your Wishes Known process provides educational materials and thought-provoking questions to help participants understand complex issues related to medical care, and develops advanced planning documents and communicates their preferences about care to healthcare providers. Okay, so then this talks about the Omnibus Budget Reconciliation Act. This states each resident in a long-term care facility is to be at their highest practicable level of physical, mental, psychosocial well-being and must emphasize the resident's rights. So basically, no matter where you're at, whether you're in a nursing home or somewhere else, you have certain rights. And this is a legal thing that, you know, if you don't feel like your rights are being followed, you can call someone like an omnibus person and they would like help you with that. So within 14 days of admission, the staff must perform comprehensive interdisciplinary assessment of every resident. And they use that as a basis for planning their care. And then they have to be given the nursing home Bill of Rights. And then the autonomy issues balancing the rights of residents with institutional needs. So usually facilities will post that residents' Bill of Rights in their facility so everyone can see it. All Medicare and Medicaid funded facilities use that minimum data set for resident assessment and care planning. So you know how this talks about, hey, I have to assess someone within 14 days of admission. Usually it's that MDS thing that they fill out. Okay, so ethical issues. So daily care issues related to older adults' values, preferences, and quality of care involves ethical dilemmas. So ethical questions and answers are often in gray areas instead of just black or white. So values clarification is a tool used to address ethical issues in everyday care. So again, you know, remember when we talked about this in our other class, we said if you come up with an ethical dilemma, you have to think, okay, what is my view on this? And make sure that your view isn't clouding your judgment on the best thing to do in the situation. And you always have different people you can go to about some of these ethical decisions if you're having an issue with trying to make the decision. Okay, holistic nursing ethics. So this is a guide in holistic decision making about ethical issues. So some of the things you would ask yourself would be, am I wise and courageous enough to perceive and respect others' differences? Honor them as I honor my own beliefs. What does the patient want? Does the patient understand his or her choices? Is the patient being coerced? What does quality of life mean for the patient? How are others responding to the patient's perceptions of quality of life? And does having technology always mean it should be used? Which that's kind of an interesting thought there. Again, our values clarification is something that's ongoing that we should always be doing. We need to be increasingly aware of what's important and just and why. Nurses can facilitate this process through listening carefully and reflecting back so the older adult clarifies what is personally important. Listing several healthcare behaviors or values such as health, happiness, independence, or good relationships. Okay, so this also gets into a little bit about restraints. So you remember there's different types of restraints. You can have physical or you can have other things that would be considered a restraint as well. So physical restraint is any device, method, equipment that immobilizes or reduces the ability of a person to move, you know, their arms or legs or body or their head freely. So there is an initiative to limit or eliminate the use of restrictive devices that infringe on a patient's rights. So reducing the use of restraints requires multi-component interventions, including institutional policy changes, staff education, consultation, and alternative interventions. So some examples of things that you could use for restraints, you know, a lot of the belts that are out there, like if you have a belt in their wheelchair to keep them in their wheelchair, that's a restraint. If you put hand mitts on them, soft wrist restraints, certain types of chairs would be considered a restraint because they have something over top of them. Full side rails in certain circumstances, you know, in the bed would be considered a restraint as well. Okay, so then this gets into a couple of like ethical type issues that you may come across. So this would be issues related to artificial nutrition and hydration. So this refers to methods of bypassing the upper GI to deliver nutritional substances due to poor nutrition intake or an inability to chew or swallow. So there's concerns raised with advanced cognitive impairment during hospitalization for acute illness that does not improve survival. So like you might be in some type of ethical decision where maybe you have a patient who, I don't know, maybe they're brain dead and they're in your hospital and the family just does not want to let go. They're like, oh, they're still alive. I want to keep them going. So they put a feeding tube in and you have to keep giving tube feeds. So that's an ethical dilemma because, you know, maybe you're just prolonging their life, but they're not really there and they're not really living it. So that's kind of an ethical thing that you may end up, you know, undergoing. Another thing they mention is issues related to long-term care settings. So the quality of care has led to more emphasis on autonomy and individual rights. Long-term care settings address ethical issues by establishing policies and procedures based on best practices. So nursing responsibility is to involve the older adults, families, and surrogate decision makers in developing plans that are safe, individualized, and respectful of the person's preferences and everyday legal or ethical issues. So ethical decisions in long-term care facilities would be like this. So, hey, should you use restrictive measures to address potential risks to safety, restricting cigarette smoking, allowing residents to refuse therapy, social activities, food, or fluids, providing more care assistance than necessary because it's more time efficient to the staff, Scheduling resident care practices for the convenience of staff rather than according to their individual preferences. Accommodating residents who wish to express sexual interests and activities. We just talked about that in that one sexual chapter recently. So there's all kinds of things that you may come across with long-term care settings that may be an ethical dilemma, according to, what you think and according to what the family thinks or what. Okay, so cultural aspects of ethical issues. So religious teachings and other cultural factors have strong influences on ethical issues, particularly with regard to advanced directives and decisions about end-of-life care. Cultural factors influence health providers' need to examine one's own biases and assure culturally competent care. So there's always, language barriers with people. So advanced directives are not always available in other languages. So the 5 Wishes document would be good to use here because I believe that has the ability to be in different languages. So that would be something that you could do. African Americans and ethnic minority populations are less likely to engage in advanced care planning. This is because of spiritual beliefs, lack of access, and knowledge about services, and historical distrust of the healthcare system. There is a page number in your chapter, page 155, box 9-3, that talks about cultural considerations, legal and ethical aspects of care. That might be good to look at. Okay, so the role of the nurse regarding legal and ethical issues. So we need to do some advanced care planning. So this is an ongoing process that's initiated when the person is healthy as a routine part of their care. It includes learning about medical conditions that may occur, treatment options for addressing them, and thinking about relevant goals, beliefs, values related to treatment. It involves formulating and communicating about preferences with all of those who will be potentially involved with decisions about that person's care. All relevant documents are prepared in accordance with legal requirements. All documents like the living will, the power of attorney, the 5 wishes, whatever, are all readily accessible to all involved decisions about the person's care. And then these documents are periodically reviewed and updated as necessary. That should be our role, with taking care of patients with this. So how can a nurse support family-focused decisions related to care for the client with advanced directives in place? Select all that apply. So it's going to be,
Yeah, pretty much ABCD.
yeah, every one of these, A, B, C, D. Okay. All right, so for this information in this chapter, you need to know about these different types of like advanced directives. So you need to know the difference between durable power of attorney, living will, know about those 5 wishes, those types of things. And then basically just kind of know how you would approach an ethical dilemma, like what you would do with those types of decisions. Okay, one more and we'll be all set. Okay, so this is about elder abuse and neglect. It's kind of sad that we even have to talk about this, but it definitely is an issue. So it's a complex, serious functional consequence affecting vulnerable older adults, which most adults are vulnerable. Most of them are. So detection, assessment, and interventions require an interdisciplinary approach. So this is what we need to know here. So elder abuse or mistreatment is defined by intentional actions causing harm or creating serious risk of harm, whether or not intended to vulnerable older adult by a caregiver or other person who stands in a trust relationship, or failure by the caregiver to satisfy older adults' basic needs or protect them from harm. So there's three basic categories. So we have domestic elder abuse, institutional elder abuse, self-neglect, or self-abuse. And, abuse comes in many different forms. So we have not only physical, we also have sexual abuse, emotional or psychological abuse, neglect, abandonment, financial material abuse or exploitation, and also self-neglect. Can you guys give me an example of something that would be emotional or psychological abuse?
Would that be like talking down on an elderly person? Like
Like
maybe,
say,
like, maybe not listening to them and using words like sweetheart, listen to what I'm saying, like something like that.
okay, maybe. So like if you witness this, like someone was doing this to an older adult, it doesn't necessarily have to be a healthcare giver. It could be someone else. So like maybe you're watching a son who is taking care of his mother and the son is talking horribly to his mother. He's saying, Mom, you just don't understand. You're not smart enough to know this. And just being really
Right.
like talking down to the mom. So that would be, emotional or psychological abuse. Other things that would be something that would kind of go with that would be if they like keep that person away from people that they love. So I had a patient I took care of years ago in the hospital who I was thinking that maybe she was getting abused. And I told, my supervisors about it. And they kind of held her one extra day in the hospital to try and figure it out. And I felt kind of bad because she ended up having to go home with him. And then they were just going to have like adult protective services come out and assess the situation. So she still ended up having to go home with them. But the things that I saw with her was that she said he would keep her from seeing all of her other relatives. Like he isolated her from other people.
That's how my uncle was with one of my aunts. She's older, and it took a while for us to get her out of that situation.
Yeah, so that's kind of a red flag that there's something wrong right there, definitely. Someone give me an example of neglect.
Would that be like having an older person at your house you're supposed to be taking care of, but then you leave them without having showered or leave them in their own places for a while or a long time,
Okay,
or underdressing them and stuff like that?
yeah, definitely. Marcedes, did you have something you were going to say too?
Um, couldn't it be like if like a caregiver said that they'll like be there and they don't ever come?
Yeah, possibly. So when you're seeing someone who's neglected, you're seeing someone's not being taken care of like they should be. So if like think about maybe an older adult in a nursing home. So how do you know they're not being taken care of good when they have all kinds of bed sores and stuff, right? So in a way
Yeah.
that's neglect, right? So
Mhm.
if you saw, like say you saw a neighbor who had a bunch of kids in their house and you knew these kids weren't being taken care of well because every time you see them, they have the same clothes on and they look really dirty and they're always hungry, like they don't have enough food. So they're being neglected, right? So that's kind of neglect. What about self-neglect? What is that?
Would that be,
Is that like,
go
go
ahead,
ahead.
Masadi, go ahead.
Would that be like for them like starving themselves, like they just let themselves go? No?
Yeah, I think so.
Okay.
What were you going to say, Stella?
I was gonna say kind of the same thing.
Okay.
That'd be when you're like doing those things to yourself, like when intentionally like not taking the necessary actions, like things you're supposed to do.
Okay.
Oh,
And you see this a lot with people who are depressed. So when
right.
someone goes into a deep depression, sometimes they'll have that self-neglect. They don't take care of themselves like they should because they're so depressed, they just can't. So that is a form of abuse. What about financial or material abuse or exploitation?
Spending someone's money because they're not able to take care of it themselves. Like, just using someone's money without their
Mm-hmm.
consent,
Okay.
making financial decisions without the person's authorization.
Yeah. So like that example I was telling you about that lady I took care of years ago, this was also an issue there. So she had money, and so that's why the son was staying with her, because she had money. And he took advantage of her money, and he would always spend a ton of it and didn't never asked her, so he was taking care of her accounts and everything, and she had no idea of even how much money she had left. So definitely. Okay. So this talks about risk factors for elder abuse and neglect. So things that would put someone at risk. So typically it's a case where someone is socially isolated and they're either physically or cognitively impaired, and someone of advanced age who lives alone or with an abuser, and they depend on the abuser for care. So like this lady I was telling you about, she was older. She was probably in her 80s, and she had a hard time taking care of like the house and things like that. So she wanted her son there to help take care of those things. And he would like make dinner for her and that type of stuff. So he isolated her from everyone. She had a lot of physically impairing things going on with her. So she was kind of vulnerable because of that. And she depended on him to help take care of certain things. So that put her more at risk. A lot of times, this talks about invisibility and vulnerability occur in most situations. So people you wouldn't always notice this in someone, that they're being abused, because it's kind of an invisible situation where you don't necessarily see it all the time. It may come out in certain senses like I wouldn't have known anything about this lady until she came into the hospital and I asked her certain questions. I definitely wouldn't have thought that anything was wrong because I didn't know. But sometimes it'll come out in certain situations where you'll see it. Common psychosocial risk factors would be impaired cognition and long-term mental illness. Boy, just imagine if you had long-term mental illness, how people could take advantage of you, you know? And then caregiver risk factors as well. So caregivers who need your money, like that guy, that would be someone who would be more at risk. Yeah, so there's a lot of things that kind of come into play here. So unfortunately, the vast majority of these cases go unreported. So there's social, personal, and situational and environmental factors that are associated with being vulnerable. And when we talk about vulnerability, this is associated with a combination of social, personal, situational, and environmental factors. Older adults are reluctant to admit to abuse or neglect, and they have a significant psychosocial limitation due to dementia, depression, and mental health issues at times. So they can have impaired judgment, lack of insight, inability to make safe decisions, and a loss of contact with reality at times. So they're going to be more at risk. And then this talks about absence of close relatives and other support persons who are willing to provide adequate assistance. So when we talk about the caregiver factors, um, these are things that might make someone more willing to do abuse to an older adult. They may be under a ton of stress about something, like maybe they just lost their job, or I don't know, they have something going on in their life that's stressing them out. They could have pathological characteristics or personality characteristics that would predispose them to being like this. They may have insufficient resources, so they don't have their own money, so they're going to try and take advantage of someone else who has it. They may have a lack of understanding of the older adult's condition, so they think that, maybe they don't understand that this person is confused, so they just think they're faking it or something, because they're ignorant about their condition. So other caregiver factors associated with elder abuse, again, you have social isolation that goes on, dependence with a co-resident, poor interpersonal relations with the dependent elder, poor health themselves. Maybe the caregiver has poor health. So that could predispose this person to neglect, because the caregiver has poor health, so they can't take care of the older adult well enough. Okay, so all right, so elder abuse and neglect in nursing homes. So recent studies indicate that elder abuse and neglect in nursing homes and other institutional settings is widespread and is a hidden problem. So again, sometimes this is because there's a lack of abuse prevention policy in the facility. It could be from insufficient staff screening, inadequate staff education and training, or even staff shortages and turnover, which I think that's probably the biggest reason. What do you guys think?
Yeah.
I mean, so when you are working short all the time and you have all of these people that want something from you, it's very stressful. So again, stress kind of plays a part in why someone would, go to this and do this. So I think that definitely is part of it. Okay, which of the following factors does not contribute to invisibility of elder abuse? Remember, does not contribute. This would be most older adults live in long-term care facilities, because that's not true. Just a very small portion of people do, and part of the reason for that is because it's so expensive. Okay, functional consequences associated with elder abuse and neglect. All right, so physical abuse. So this is inflicting and threatening to inflict physical pain or injury to deprive a basic need. Sexual abuse. Non-consensual sexual contact of any kind, coercing to witness sexual behavior would be another thing that would go with that. Emotional or psychological abuse, inflicting mental pain, anguish, and distress through verbal or nonverbal acts. Financial exploitation, illegal taking, misuse, or concealment of funds, property, or assets. Neglect would be refusal or failure to provide food, shelter, or health care or protection. Abandonment, so desertion by anyone who assumed responsibility for care. And then self-neglect, threats to his or her own health or safety. So what is the definition of exploitation as a form of abuse? This is going to be illegal taking, misuse, or concealment of funds, property, or assets. Okay, so when we talk about assessment of someone who we think might be, suffering from abuse, elder abuse is a hidden problem, so we need to really look closely to see if this is actually something that's happening. So assessment begins with suspicion about its existence. So a home visit is an essential component here. So like in that situation I was telling you guys about, they ended up sending Adult Protective Services to the house to check on them. And so that would be the home visit to see if there really is anything that's unusual going on there. It's always difficult to determine the onset of abuse. Clues may be ignored in hopes that the situation will resolve by itself. So people need to be willing to share things with you sometimes for you to even know that something's going on. In what way does assessment of elder abuse differ from usual nursing? This is going to be a major focus is to determine whether legal interventions are necessary. All right, so with physical health is a little easier to, kind of assess for compared to some of this other stuff. So nutrition and hydration. This would be very serious thing if this person was being deprived of some of that. So if you were doing an assessment on someone and you were trying to see if they were deprived of these things, you would see that they were very cachexic, meaning that they lost a lot of weight and they look really skinny. They may have like fat hanging off of them because they're so skinny. They may look really dehydrated, so they're going to have dry lips, dry mucous membranes. Their skin turgor is going to be, tenting, all of that kind of stuff. Other things that we would see physically: injuries, bruises, and other physical harm, poor wound healing, burns from a stove, cigarette, or hot water, bruises, swelling, or injuries from falls, especially repeated falls. So more than one of these indicates at the same time or over a short period of time that there is an issue. So they should raise a high level of suspicion about neglect. Characteristics of bruises are routinely assessed for information about onset and progression. And then this talks about the degree of frailty. So an older adult who is physically healthy and fully ambulatory would not have the same degree of risk for fall-related injuries as someone who is 78 pounds and ambulates unsteadily. So if someone is like that, where they're really tiny and they're very unsteady, they're going to be more frail compared to a regular person. And then pathological conditions. So consequences can be quite serious when a person with diabetes or heart failure does not take medications correctly. So again, that could be something that maybe their caregiver isn't giving them their medications like they should be, or they're not taking them. All right, with activities of daily living, we want to make sure this person is safe doing these things, and we want to look at their home environment to make sure things aren't set up to where they're going to have all kinds of safety issues. We want to make sure their basic needs are being met, and then that they don't have any kind of functional or environmental conditions that's causing them to have an issue. So adequate nutrition, hydration, and the ability to obtain help in an emergency are basic human needs that are most often called into question in cases of elder abuse. When we look at psychosocial function, this is the capacity for reasonable judgment about self-care. So when the competence of an older adult to make safe decisions regarding self-care is in doubt, nurses may be legally bound to make reports or consider other legal interventions. Nurses promote self-determination for older adults by respecting their rights to make decisions about their care as long as their actions don't jeopardize safety for themselves or others. Okay, so support resources. These include caregivers, friends, relatives, and significant others who influence person's physical and psychosocial function. So caregivers can be perpetrators. So it's not unusual to address situations in which an alcoholic son or daughter lives with a parent and provides emotional support while at the same time neglecting the parent's needs and financially exploiting them. And then assessment of barriers to the use of resources. So does the caregiver need to use respite care to get a break? Assess the caregiver's knowledge about the elder's medical needs. They may have had good intentions by buying them adult briefs for incontinence, but maybe didn't know that sitting in a wet brief can cause skin breakdown. So with environmental influences, We want to assess their environment for any kind of risks, safety of their living conditions, the safety of the neighborhood, seasonal factors like hypothermia and heat-related illness. Is there lots of clutter? Are they a hoarder? Communicate a non-judgmental approach as you're looking into this stuff. With threats to life. So identify life-threatening situations or serious medical risks. Assess urgency, seriousness of situation with opinion regarding legal interventions that are justified. Initial assessment aimed at determining immediate threats to life. So you also want to assess suicide potential. So threats to assess would be history of physical violence as part of the caregiver, on the part of the caregiver, untreated wounds or infections, progressive gangrene, inability to adhere to therapeutic regimen, misuse of medications, or excessive use of drugs and alcohol. And then with cultural aspects, there is a good thing to look at in your book on page 176, box 10-3, talks about cultural considerations assessing elder abuse. So I would definitely look at that. Some of the things you would look at would be the family and cultural expectations, perspectives on caregiving, and barriers to assessment. So what's the most immediate nursing consideration in determining whether legal intervention is necessary in an abusive situation? So this would be your threats to life. So with nursing diagnoses that we could use potentially here, so compromised family coping, disabled family coping, caregiver role strain, risk for injury, or decisional conflict. With compromised family coping, this is a usually supportive primary person provides insufficient, ineffective, or compromised support, comfort, or assistance, or encouragement that may be needed by the older adult to manage or master adaptive tasks related to his or her health challenge. All right, so as we're planning for wellness outcomes, these would be some things that we might want to address for goals. So we want to see that they get some social support, that they have better family coping, that they're not neglected anymore, that they're not getting abused anymore by different ways. So some of the interventions we could do. So interventions involve legal actions when decision-making abilities are impaired. So you may have to look at competency. Nurses have to be advocates for older adults. Interventions in institutional settings. So when a vulnerable older adult is in a long-term care setting, nurses must address psychosocial needs of the family caregivers by providing support and education. These are effective tools for preventing elder abuse. Also with a community setting, give professional advice about how to deal with dementia patients with difficult behaviors, find ways to alleviate stress associated with the demands of caregiving. And then with interdisciplinary teams, these provide holistic perspective, which is essential for thoroughly assessing the problem and determining appropriate solutions. And then facilitating referrals. So for services that improve functioning of how the older adult is and also decrease the burden of caregiving. And then with prevention and treatment services, maybe we get them information about protective services or a crisis hotline or emergency shelter, or maybe we get them mental health counseling or alcohol and drug treatment. Or with prevention, maybe we train them in caregiving a little bit better, and then educational programs against elder abuse. So we kind of talked about these things. Okay, which of the following is not a nursing intervention to reduce caregiver stress and thus the potential for abuse? This would be proposing admission to a long-term care facility. That's not going to be a solution. Okay, so with interdisciplinary teams, hospitals often have teams of people that look into elder abuse. So that could be something. There's different case management services that sometimes can be offered so that more people are involved to kind of keep an eye on this person. We need to do thorough assessments, and nurses need to be creative if interdisciplinary teams are not in place. With referrals, we need to assess their willingness to accept help, maybe get them some medical equipment and supplies and assistive devices to improve function and safety. And then with prevention and treatment interventions, we need, it kind of just depends on the situation. So there's all kinds of different programs like for preventing financial abuse. It just depends on what they need is what you would hook them up with. And then legal interventions and ethical issues. Involuntary legal intervention is indicated when an assessment reveals that decisions must be made about an older person's health, living arrangements, money, or property. The older person is not capable of making reasonable decisions. There is a risk to the older person's health, safety, money, or property. The risk would be reduced or eliminated if someone else were empowered to make the implemented decisions. So with adult protective services, this provides protection for a person who is abused. There's no federal guidelines or specific funding. Services differ in every state. Facilitating identification of abuse and neglect. So the purposes of state laws for protecting older adults who are vulnerable, that's what the purpose of it is. Most states protect confidentiality of reports. So if you do report someone, they're not going to tell them who reported them. In some states, failure to report does have a penalty. And mandatory reporting laws do not require reporters to know whether abuse or neglect has occurred, but merely report if they suspect it. So that's kind of important to know. Which statement is true regarding mandatory reporting laws? Laws do not require reporters to know whether abuse has occurred, so you just have to suspect that it has occurred. Okay, ethical issues. All adults in America have rights, so they should have freedom from intrusion, right to fair treatment, freedom from unnecessary restraint, right to self-determination. All can be taken away through the use of legal measures. And then with evaluating the effectiveness of our interventions, hopefully you would see a stress reduction with a caregiver, a higher level of functional independence, least restrictive legal interventions, and protection of that older adult. Okay, so that's that stuff. So you guys wanted to know specific chapters for this next test. So give me 1 second, I'm looking it up here. Okay. So for test 4, you would be looking at chapter 18 and 19, which is about digestion and nutrition and urinary function. You would be looking at 16 and 17, which talked about hearing and vision.
16 and 17.
Yep. And you'd also look at 24, 25, and 26. That would be sleep and rest, thermoregulation, and sexual functioning.
Okay.
So that would be exam 4. The stuff that I just went over today, this will be stuff that would be included on your final.
Today's lecture is finals.
Yes.
And we have 18, 19, 16, 17, 24, 25, and 26.
Yes.
Okay. Thank you.
Did you say chapter 19 was a part of it or no?
So again, for test 4, it's chapter 18, 19, 16, 17, 24, 25, 26.
Okay.
Okay. All right, guys. So next week we'll come on here, we'll do our test, and that'll be that.
Okay.
All right. If you have any questions, let me know. You guys have a
Okay.
good rest of the day.
You too. Thank you.